Good evening, everybody. I'm Dr. Nguyen Hà from Vietnam. First of all, I would like to pay my gratitude to GE, who gave me the opportunity to deliver the presentation today. My topic today is about ectopic pregnancy in unusual location. We know ectopic pregnancy occurs when the plastic implantation takes place outside of the endometrial cavity, and the prevalence is about 1.4% of all pregnancy. Determination of the pregnancy size in early pregnancy is challenging due to the small size and non-specific appearance of the gestational sac. So ectopic pregnancy is still the leading cause of maternal morbidity and mortality in the first trimester pregnancy. We know abnormal fallopian tube function, which inhibits normal implantation of a fertilized ovum within the uterine cavity, may be the cause of ectopic pregnancy. So the risk factor of pelvic include pelvic inflammatory disease, tubal surgery, fertility treatment, intrauterine device, endometriosis. However, 50% of ectopic pregnancy without known risk factor. Transvaginal examination is the first-line modality for the detection of an ectopic pregnancy. If a TVS cannot find pregnancy, we need a thorough trans-abdominal examination to look for rarer location. And MRI is an adjunction to ultrasonography for equivocal cases. My lecture today is prepared based on X-ray recommendation for good practice delivered in 2020. So, as recommendation by X-ray, ectopic pregnancy should be classified as uterine and extrauterine. Previous classification as tubal and non-tubal should be abandoned, and I think this classification is really useful in our daily practice. So I will present ectopic pregnancy in 3 groups as recommended by X-ray. Uterine ectopic pregnancy includes CESAREAN SCAR pregnancy, cervical ectopic pregnancy, intramural ectopic pregnancy, and extrauterine ectopic pregnancy include tubal ectopic pregnancy, ovarian ectopic pregnancy, abdominal ectopic pregnancy. And the third group is about rudimentary heart pregnancy and heterotopic pregnancy. Uterine ectopic pregnancy defined by evidence of trophoblast invasion beyond endometrial myometrial junction, but not outside uterine visceral ligament. In many cases, the GS is only partially invading in the myometrium. So uterine ectopic pregnancy should be declared as partial or complete, regardless of the depth of invasion. CESAREAN SCAR pregnancy occurs when the embryo implant in the fibrous scar tissue of a previous cesarean section. It constitutes less than 1% of all ectopic pregnancy and estimated about 1 in 2,000 pregnancy. And the clinical cause depends on the depth of implantation. If the GS located superficial and extends toward the uterine cavity, the pregnancy can proceed to term, though with higher morbidity due to abnormal adherent placentation. And if the GS located deep within the defect, the high risk of uterine rupture with life-threatening bleeding in the first trimester. Ultrasound criteria for diagnosis suggested by Koch in 2016 include empty uterine cavity, empty endocervical canal. We can see the GS or a solid mass of trophoblast embedded at side of cesarean section. The myometrium between the GS and the bladder is thin or absent. And on color Doppler, we can see the evidence of troponin circulation. CESAREAN SCAR pregnancy also subdivide to partial or complete. For partial form, the GS invading the myometrium but also protruding into the uterine cavity. For the complete form, the GS completely implanted within the anterior of myometrium and without the visible communication with the uterine cavity. We know that the CESAREAN SCAR pregnancy is a precursor of Placenta Acreta Spectrum, both sharing the same histopathology. And on ultrasound, we can see they are very similarly with the lacunaire, thin myometrium, high vascularity at the uterine bladder interface. This is a case of partial CESAREAN SCAR pregnancy. You can see the GS partial invading the anterior myometrium but also protruding into the cavity of the uterine. The couple would like to carry on the pregnancy, so we continue to follow up. The same patient at 9 weeks, trans-abdominal scan and trans-vaginal scan. We can see the GS extend toward the cavity and migrate to the fundus, but the placenta still there in the niche. This is an important sign for diagnosis of CESAREAN SCAR pregnancy after 7 weeks, when the low-lying may not seen anymore. And the same patient at 11 weeks, we can see nearly all signs of a Placenta Acreta lie in the third trimester. And at 32 weeks, the ultrasound finding of Placenta Acreta like lacunaire, lost myometrium, increased vascularity, and in the uterine bladder interface. Cervical pregnancy is another rare type of ectopic pregnancy. It is defined as the implantation of pregnancy into the cervical stroma below the internal os, account less than 1% of all ectopic pregnancy and about 1 in 9,000 pregnancy. Criteria suggesting for diagnosis of a cervical pregnancy include empty uterine cavity, decidual transformation of the endometrium with a dense echo structure, hourglass uterine shape, balloon cervical canal, gestational sac, placenta tissue in the cervical, and the important thing is closed internal os. Cervical pregnancy also be classified as partial or complete, depending on the presence or absence of their communication with the cervical canal. Cervical pregnancy must be distinguished from abortion in progress. In abortion in progress, because the GS is passing the cervical canal, so you can see the internal cervical os open, and on the Doppler we don't see the flow around the GS. A technique may be useful for different diagnosis is sliding sign. Because in abortion in progress, the GS is passing the canal, so when you compress the probe, you can see the GS sliding and deformable. In contrast, for the cervical ectopic pregnancy, the GS is embedded within the stroma. It is fixed here, so when you compress the probe, the GS not sliding and not be deformed. Cervical pregnancy also must be distinguished with CESAREAN SCAR pregnancy, and the key point is for the cervical pregnancy, the GS under the internal cervical os, and the CESAREAN SCAR, the GS is above the internal cervical os. However, as X-ray recommendation, all pregnancy implanted into the posterior cervix should be described as a cervical ectopic pregnancy regardless of history of delivery by cesarean section, And in case of anterior implantation in women with a cesarean scar in the past, the differential diagnosis includes cesarean scar pregnancy. However, in terms of management, they differ very little from a cervical pregnancy and cesarean scar pregnancy. Another rare type of uterine ectopic pregnancy is intramural pregnancy. It is extremely rare, with less than 50 cases described in English literature. The etiology is unclear, but it believed that blastocyst implanted into the uterine myometrium due to underlying adenomyosis or a focal endometrial defect caused by IVF, DNC, or myomectomy. Ultrasound suggesting of an intramural pregnancy when we see the GS located within the uterus but bridge the endometrial myometrial junction and invade the myometrium of the uterine corpus above the internal os. We know 3D ultrasound and MRI can visualize the endometrial myometrial junction better than 2D ultrasound, so they can help to rule out intrauterine pregnancy mimicking an intramural ectopic pregnancy. And degenerating fibroid may also mimic an intramural pregnancy. This is a case of intramural pregnancy, sagittal plan and ASEAN plan. We can see the GS with the Johnsack inside implanted in the posterior wall of the uterine. And on the color Doppler, we can see the prominent peritrophoblast blood flow. So this is an intramural pregnancy. And like other uterine ectopic pregnancy, intramural pregnancy also divided to partial or complete. For partial, the GS implanted within the myometrium but also protruding into the uterine cavity. And for the complete form, the GS implanted completely within the myometrium and not in the interstitial portion. Another case of intramural pregnancy, and you can see this is a patient had the adenomyosis. So you can see the uterus global with the shadowing, and you can see here the GS on the ASEAN plan and sagittal plan. We can see a GS implanted in the posterior wall of the uterine, and on color Doppler we can see prominent peritrophoblast blood flow. We think this is the intramural pregnancy. However, because adenomyosis may deviate the ectopic GS, so we do MRI to confirm. And on MRI, we can see very clearly that this is the GS implanted in the posterior of the uterine wall and combined with the adenomyosis. The scan after 3 days of laparoscopy, we take off the GS and we don't see anymore. And a case to see this is the degenerating fibroid, and we know that it may mimic an intramural ectopic pregnancy. And now we move to the second group of ectopic pregnancy. Is the extrauterine ectopic pregnancy. Tubal ectopic pregnancy occurs when the blastocyst implanted into the fallopian tube, and also referred to as the adnexal ectopic pregnancy. It constitutes more than 95% of all ectopic pregnancy, and ampullary ectopic pregnancy is the most common with about 70% of all tubal ectopic pregnancy. Depending on their location, tubal ectopic pregnancy can be subclassified into interstitial, isthmic, and ampullary. Fibroid ectopic pregnancy also be described, but only be diagnosed as surgery, and on ultrasound very difficult to distinguish from an ampullary ectopic pregnancy. On ultrasound, a tubal ectopic pregnancy can see the tubal ring sign or Bagon sign. It is a hyper-echogenic ring surrounding an extrauterine gestational sac, and this mass must be separate from the ovary. On color Doppler, we can see the ring of fire sign. This is a peripheral hypervascularity of the echogenic ring. However, this is a non-specific finding because we can see in the corpus lutein 6. This is an interesting case. You can see the uterus is empty and a live pregnancy outside of the uterus with a live fetus about 11 weeks. At first, we thought it may be an abdominal pregnancy because a tubal pregnancy cannot go beyond 10 weeks. However, when we saw the pregnancy change position after the bladder empty, we cannot exclude a tubal ectopic pregnancy because the abdominal pregnancy we usually see it fixed and not smooth, and laparoscopy confirmed it was a tubal ectopic pregnancy. Interstitial segment is the segment of fallopian tube that lies within the muscular wall of the uterus. And interstitial ectopic pregnancy, we can see the GS located lateral in the interstitial part of the fallopian tube and enveloped partially by the myometrium. This is the least common form of tubal ectopic pregnancy, with about 1 to 3% of all ectopic pregnancy, and surrounded by a myometrium tissue, so the pregnancy may develop further to the second trimester, and rupture of such an advanced gestation may result in a catastrophic hemorrhage with a higher mortality, and the diagnosis is challenging due to the difficulty in differentiating from an eccentric high-lying intrauterine pregnancy. On ultrasound, you can see a gestational sac located eccentrically and outside of the endometrial cavity, and we also see a thin rim of myometrium tissue around the gestational sac. The critical diagnostic feature of interstitial ectopic pregnancy is the interstitial line sign. It's a thin endometrial line extending directly to the center of gestational sac, and this sign is said to have a sensitive about 40% and specific 90%. Another case of interstitial ectopic pregnancy in 2D and color Doppler. And on color Doppler, you can see the prominence of vascularity around the gestational sac, very prominent, because in the interstitial ectopic pregnancy, the trophoblast is set invade in the myometrium is more than normal, so you can see look like in Placenta Acreta. Some interstitial ectopic pregnancies spread out medially and protrude into the upper lateral aspect of uteri, so it's really hard to differentiate from eccentric intrauterine pregnancy. So if the myometrial thickness under 5 mm is indicative of interstitial ectopic pregnancy, whereas if above 5 mm suggests eccentric intrauterine pregnancy. This is a case of interstitial ectopic pregnancy at 12 weeks. Transvaginal scan, you can see the uterus cavity empty, and you can see the pregnancy on the top on the right side of the uterine and focus on the fetus. You can see it's surrounded by a myometrial tissue, and within this is the interstitial ectopic pregnancy. And on color Doppler, the prominent vascularity around the fetus. Laparoscopy, we can see this is the uterus with the interstitial ectopic pregnancy in the right side. Ovarian ectopic pregnancy occur when the blastocyst implant into or on the ovary. It's a rare event with about 1 to 3% of all ectopic pregnancy. The exact etiology is unknown, but possible mechanism is the secondary implantation of the embryo or a failure of follicular extrusion. The accurate preoperative diagnosis of ovarian ectopic pregnancy remains challenging. On ultrasound, we can see a heterogeneous structure with an echogenic wall that is inseparable from the ovary. And we also see the ovary cortex around the mass. Ovary ectopic pregnancy can be confused with a hemorrhage corpus luteum, ovarian cyst, or a tubal pregnancy. However, for ovarian ectopic pregnancy, because the trophoblast tissue, so it makes the wall of the mass thicker and more echogenic if we compare with a corpus luteum or ovarian cyst or tubal pregnancy. And on color Doppler, we can see the double ring of fire. Normally, we can see the ring of fire in corpus luteum, but for the ovarian ectopic pregnancy, besides a ring of fire of corpus luteum, you can see another area of increased vascularity within the ovary. This is the peritrophoblast flow. Abdominal ectopic pregnancy occurs when the blastocyst implanted in the peritoneal cavity outside of the uterus, ovary, and fallopian tube. And the most common sign of the abdominal ectopic pregnancy is a pulse around the uterus in the serosal surface of the uterus and fallopian tube. And the pregnancy can go undetected until an advanced gestational age and often result in a severe hemorrhage. So the rate of maternal mortality has been reported high at 20%. Abdominal pregnancy can be classified based on the gestational age of diagnosis: early if the diagnosis as or before 20 weeks, and advanced if the diagnosis after 20 weeks of gestational age. It can also be classified as primary. It's rarely when the ovum directly implanted into the peritoneal cavity, or secondary implantation from an aborted tubal pregnancy. Ultrasonographic findings suggesting an abdominal ectopic pregnancy include fetus outside the uterus. We cannot see the uterine wall around the fetus. The fetal part close to the maternal abdominal wall, eccentric position of the fetus, placenta outside of the uterine cavity, placenta adjacent to the fetal chest and head with no amniotic fluid. Different diagnoses of abdominal ectopic pregnancy include: first, tubal ectopic pregnancy. In early stage and if implanted in the pelvic region, it is difficult to distinguish an abdominal ectopic pregnancy from a tubal ectopic pregnancy. For the tubal ectopic pregnancy, we usually see the GS located lateral to the uterus, while in abdominal ectopic pregnancy, the GS is seen in the pulse of doulas, and tubal ectopic pregnancy rarely go beyond 10 weeks without rupture, and the GS movable compared with the abdominal ectopic pregnancy. The second diagnostic difference is the pregnancy in rudimentary heart pregnancy, and the key criteria supporting the diagnosis is the presence of myometrium tissue around the rudimentary heart pregnancy, which is absent in abdominal pregnancy. However, it is not easy to identify the myometrium in advanced stage, so MRI can confirm presence or lack of myometrium and help to differentiate between the abdominal ectopic pregnancy and rudimentary heart pregnancy. This is a case of abdominal ectopic pregnancy in pulse of doula on 2D and on color Doppler transabdominal, and we can see the gestational sac with a live fetus inside in posterior wall of the uterine. It means in the pulse of doula. And this is the transabdominal. You can see this is the uterus and this is the gestational sac, and the gestational sac attacked in the posterior wall of the uterus, and we do not see the myometrium around the gestational sac, so we think this is the abdominal ectopic pregnancy. And this is the photo when laparoscopy, and we can see this the uterus, and beside the uterus in the pulse of doula we can see the mass, and when the overlying cloth removed, the underlying ectopic pregnancy we can see in the pulse of doula. Hepatic pregnancy is extremely rare and dangerous form of abdominal ectopic pregnancy, under 20K reported in literature. The mechanism of ectopic pregnancy in the liver is complicated and remains unclear. Transvaginal ultrasound showing an empty uterus and normal bilateral agnation. Transabdominal ultrasound, we can see a mixed echogenic mass with a smooth and regular edge attached to the surface of the liver. CT and MRI not only confirm the implantation site but also clarify the anatomical relation for planning surgery. So this is a case of hepatic pregnancy, transabdominal in the liver. We can see this the liver, the gallbladder, and we can see the mass with echogenic rim of tissue surrounding the sonolution center in the left hepatic lobe. And on the color Doppler, we can see the peripheral vasculary, this is the ring of 5 sides of the gestational sac. So we think this is the hepatic pregnancy, but we do the MRI to confirm. And on the MRI, we can see a lesion in the hepatic subsemen 4B with low signal intensity on T1 and high signal on T2, suggest this is the hepatic pregnancy. And due to beta HCG decrease nearly a half after 2 weeks of follow, and the patient is in stable condition, so we continue to follow up, do nothing. And this is the scan 6 weeks later. We can see the hypoechogenic decrease. However, the peripheral vascularity and the size of the gestational sac nearly the same, but the beta HCG is decreased more. And this is the scan about 12 weeks later. The mass become more heterogeneous and the size is much more smaller, and on the color Doppler nearly no the vascularity. Beta HCG decrease so significant. Retroperitoneal ectopic pregnancy is an extremely rare type of abdominal pregnancy with less than 25 cases reported in literature. Retroperitoneal location probably involve trophoblastic invasion after primary abdominal pregnancy or via lymphatic route. MRI may prove useful in therapy location the pregnancy and guiding its surgical management. And this is a sample of retroperitoneal ectopic pregnancy. Transabdominal scan, we can see a mass composed of a peripheral hyper-echogenic gene with a hypo-echogenic center in the left para-aortic region. And we do MRI, we can see a lesion with low signal intensity in T1 and high signal on T2 below the left kidney vessel and above the division of abdominal aortic about 2.7 cm, suggesting this is a retroperitoneal ectopic pregnancy. And now I will talk the two last forms of ectopic pregnancy is rudimentary heart pregnancy and heterotopic pregnancy. Rudimentary heart pregnancy refers to a pregnancy in the rudimentary heart of a unicornuate uterus. Incidence is about 1 in 70,000 to 1 in 150,000 pregnancies. And if not diagnosed early, they can advance well into the second trimester and present with a severe pain and rupture. Ultrasonographic findings suggesting a rudimentary heart pregnancy include pseudopuncture of an asymmetrical bicornuate uterus, a single interstitial portion in the main unicornuate, the GS completely surrounded by a myometrium and separate from the unicornuate cavity, absent continuity between the cervical canal and the lumen of the pregnant heart. And this is a case of rudimentary heart pregnancy. Transvaginal scan, you can see a pseudo pattern of asymmetrical bicornuate uterus, left side and right side. And on the right side, you can see the GS completely surrounded by a myometrium and separate from the unicornuate cavity. And you see only one cervical, and the cervical canal is continuing with the lumen of the main unicornuate in the left side. And this is the photo on the laparoscopy. You can see this is the rudimentary heart pregnancy. And this is another case of rudimentary heart pregnancy as sitting weak. And the main unicorn uterus on left side, and on right side you can see the rudimentary heart with a pregnancy inside. And we look carefully at the myometrium around the fetus, so you can confirm this is a rudimentary heart pregnancy. We can exclude this is the abdomen pregnancy, because in the abdomen pregnancy we cannot see the myometrium around the fetus. However, with this MRI to confirm the diagnosis, and the MRI we can see then on the left side this is the unicornuate uterus, and on the right side this is the rudimentary heart pregnancy. And this is the photo when laparoscopy. This is the rudimentary heart with the pregnancy inside, and this is the main unicorn. The common misdiagnosis on ultrasound of a rudimentary heart pregnancy include a bicornuate uterus with pregnancy in one heart, uterus, the then fixed or abdominal pregnancy. So to make the differential diagnosis, you need to check the lumen of the cervical canal containing with the uterus, containing or not containing the fetus. And this is the case of the rudimentary heart pregnancy, and this is the case of the intrauterine pregnancy in an anomaly uterus like bicornuate or DIFFERENTIAL. And now I will talk about the last form of ectopic pregnancy. It's a heterotopic pregnancy. Heterotopic pregnancy is defined as simultaneously occurring of an intrauterine pregnancy and an ectopic pregnancy. The incidence is about 1 in 30,000 in general population. However, up to 1 to 3% among cases of ascending reproduction. It is crucial to remember that the presence of an intrauterine pregnancy does not exclude an ectopic pregnancy, especially in an ascending conception. This is a case of heterotopic pregnancy. You can see a GS into the cavity of the uterus with the yolk sac inside, and we also see another GS in the interstitial on the left side. And this is on the Doppler. You can see two GS, intrauterine pregnancy and interstitial ectopic pregnancy. And this is the 3D photo. You can see a normal GS, intrauterine pregnancy, and interstitial ectopic pregnancy in the left side. The same patient as 8 weeks. The GS intrauterine continue to grow, and the interstitial ectopic pregnancy in the left side seems stable. So we continue to follow up. And this is the 3D photo at 8 weeks. And the same patient at 12 weeks. You can see the interstitial ectopic pregnancy smaller. This is 2D, and this is the Doppler. And this is at 16 weeks. The interstitial ectopic pregnancy also smaller. Conclusion. Complications of ectopic pregnancy are still the leading cause of maternal morbidity and mortality in the first trimester. Early diagnosis is critical to initiate treatment before rupture. And ultrasound sonographic findings differ with different ectopic pregnancy locations. MRI is useful for challenging cases. Thank you very much for your attention. Stay well.